case, what we're talking about is blood stem cells, where we're essentially replacing the immune system with another immune system. So this study was done by a collaborative group, and the lead centers on this were the University of Washington and the Fred Hutch Cancer Research Center. The Fred Hutch is where all the oncologists that do the actual transplants are located. And there's actually six universities that are in a consortium that participated in this study, and we have external review and advisory panels. This slide, when I put it in here, made absolute sense to put it here, but now this is really, here's a testimony to how at midnight on Sunday night it makes no sense at all. So I'm going to skip it and come back to it when it makes sense. Well, first, the rationale for why we would do this. One is that for MS, we believe the immune system is either the cause of the disease, or if it's not the cause, at least a prominent bad player that we would like to change. Another is that EAE, which is the animal model for MS, is basically an autoimmune model, and if you treat it with high-dose immune suppressive therapy, you can essentially cure it. Also, there are some early studies in patients with MS that suggest that this might be helpful in humans. For example, there are some handful of cases that are unfortunate enough to have MS and a cancer of some sort. So they got transplanted because of the cancer, and then in most cases their MS remained stable. So for these reasons, we decided that it made sense to proceed with a human trial. These are a review of the studies that have been done with this treatment to date. The City of Hope did 5 cases, and they're one of the members of our consortium, so cases subsequent to this 5 were part of our series. But on this, these patients were doing quite badly from an MS standpoint to start with. And following transplant, one patient got worse out of the 5. The gadolinium enhancement on MRI was suppressed. However, they had 2 deaths from infections. There's a Canadian study that now may have a little more than 7, but when I put the slide together, they had 7 cases. All those 7 are stable, both clinically and by MRI. They had 1 death from veno-occlusive disease, which the veins in the liver clot and stop blood flow to the liver. Northwestern in Chicago has 21 cases, and 5 of 9 of those that had active MRI lesions continued to have activity. The patients that had EDSS greater than 6, which means they would need, a 6 means you need 1 cane, so greater than 6 means you need 2 canes or more. 8 of 12 of those were stable, but if they were less than that on the EDSS, then all of them were stable. This treatment's also being looked at in Europe, and the FASIS study had 24 cases. They had 1 death, again from an infection. 78% of those were stable at 40 months. They felt that people with primary progressive did worse, so they're not recommending it for primary progressive MS at this point. There's an Italian study with 10. All of those have stable MRIs beyond 3 months. And then there's a broader European study with 85. They've had 7 deaths. 2 of those were due to advanced MS, and 5 of those were related to the treatment directly. So of that group, about 80% are stable on follow-up. So let me go back now to the slide. If you go back to the one I skipped. That one, yeah. So our inclusion criteria, we would take any kind of MS, and we selected people with an EDSS of 5.5 to 8. So 5.5 is just on the verge of needing a cane, and 8 means you're completely wheelchair bound. We selected this group because we thought there would be some danger to this treatment, and we thought it'd probably be best to do that in people with more advanced disease rather than subjecting people very early in the course to this treatment. We also required that they have very aggressive disease, so they had to decline by 1 point on the EDSS in the year previous to our enrolling them. And that had to be documented in their chart. We had several patients that tried to sneak in that claimed they got worse, but when their chart arrived, it really hadn't. The ages of 18 to 60 is because once you get beyond 60, the risk of transplant goes up considerably. And this is how we do it. We screen them to make sure they're appropriate, and then we measure our baseline outcome measures, their physical exam and things like that. We do a spinal tap on them. We then have to mobilize their stem cells, and we do this by giving them GCSF, which is a growth factor for your blood, and it makes you pump out a lot of stem cells. And then we pherese them to gather the stem cells and concentrate them. We give about 3.5 million stem cells, and we at the same time collect another 3.5 million to freeze as a backup in case something goes wrong. And then we give them chemotherapy and radiation therapy enough to kill off their existing bone marrow, and then we transplant them back with their own cells. You would think that it would make more sense to transplant them with somebody else's cells, but the reason we chose not to do that is that would have about a 30% mortality with the current technology, and we just thought that was unacceptable. So giving them their own cells has a much lower mortality. Also, it's believed that when you transplant them, even if it's their own cells, when those cells start growing and repopulating the bone marrow, they have to go through all of the stages that you would in an embryo again, including deleting clones of these cells that are directed against self-targets. So the hope is we could eliminate autoimmune cells, even though it's their own cells we're giving them back. These are the characteristics of the patients that we enrolled. There are 26 patients altogether. We've followed them up. The mean follow-up now is 3 years. Our plan is to follow everybody for 5 years, and some people are already out past 5 years. They were 41 years of age on average. Most of them were secondary progressive MS. Their mean disability was a 7, which means that for the most part they're in a wheelchair, but they can take a few steps if they need to. 6 of them had enhancing MRIs at the time they were enrolled, and really they had all failed one of the conventional therapies before they entered this one. The main goal of this study was it was a phase 1 study, which is to try to get the bugs worked out of the system and figure out what the toxicities were and how to do it safely. And with the adverse events, it's clear that we actually found a few problems with the protocol. One was that when you give GCSF to mobilize their stem cells, it revs up their bone marrow, and we found out that you can actually cause MS attacks by doing so. There were 4 cases after we found a case in our group. We started looking around, and it turns out there have been 4 cases of MS that this has happened to. So subsequent to the first few cases, when we realized this, we had to add steroids during this stage of the procedure so that we could ward off attacks while we're revving their bone marrow up. The other thing is that any of you who have MS know that MS and fevers don't get along very well at all. In fact, it's the basis before MRI and these fancy new tests came along. They used to do the hot bath test to diagnose it because people did so badly when their body temperature was raised. You could diagnose it just by putting them in a hot bath and raising their temperature. But our oncologists didn't know that. and several people got fevers and did badly with that. In particular, about a week or 10 days out from when you give them the transplant, as the new white blood cells start to grow in, they pump out a lot of cytokines and give people fevers, and it's called the engraftment syndrome. So once we discovered that, then we had to add a second course of steroids to ward off the engraftment syndrome. And since we did that, we haven't had any additional trouble there. The third major complication was this one. And this is, we've had one fatality in the group, and this was that one. After we transplant people, we give them ATG, which is anti-thymocyte globulin, which is used to suppress their white cells further. And we usually use horse serum for this. And this particular person was allergic to horses, so we gave her rabbit ATG. And 53 days later, she got this post-transplant lymphoproliferative disorder, which is an infection with an EB virus that really behaves like leukemia, and it's untreatable and fatal. This, as I said, was our only death in the study, but there's now been 8 cases of transplant deaths from this, and they're all related to rabbit ATG. So subsequent to that, the rabbits, we don't use rabbit ATG, we just use horse. And if they're allergic to horse, then we just don't use it. The rest of these side effects were actually pretty mild. They resolved, and most of them were asymptomatic. Well, how did they do clinically? Well, it's hard to say for certain because this is a phase 1 study without a control group. So we always have to be careful about a placebo response, especially in something as obvious to the patients as a bone marrow transplant. But looking at the EDSS, which is the disability scale that we use for MS, 6 patients got worse by 1 point, and 9 got worse by a half point. Now, this scale is a difficult scale to use, and a half point is within the noise limit of the test, so you can't make much out of that. But 1 full point is considered outside the noise limit, so you can probably believe that. So 6 got worse, 2 actually got better by a half point, and 14 remained unchanged. So this is actually probably pretty good considering that we were taking the worst of the worst cases to enroll in the first place. If you look at MRI, one person's MRI got worse during the mobilization with that GCSF. So we think now probably that one worsening on the MRI we could prevent by giving them the steroids at the same time. There were 2 new or enhancing lesions out of the entire bunch on all this follow-up, so their MRI scans really cooled off. And looking at the lesion load counting the total volume of plaques, they slightly improved. And this is just a graph of what the outcomes have been. The survival is estimated that it's about 91%. One of those deaths was directly related to the transplant. There's now been 3 deaths total, but the other 2 were related to MS. These were patients that were essentially bedbound and then got pneumonia. And they were several years out from the transplant, so it was probably not directly related. The disease progression, it looks like 27% of them have some recurrence of their disease, which would make 73% of them stable at 3 years. Again, we don't know how to compare this. There is no comparison group in this study, but we think that this might be an improvement from their natural history given how bad they were when we enrolled. This, over the past few weeks, we've looked at the data further and divided it into the primary versus the secondary MS patients. And since we did this study, a lot of people have come out and stated that primary progressive MS does not have much inflammatory component. It's a degenerative disease, and that really we shouldn't be thinking about treating primary progressive with immune-directed treatments. But We did our study before that. So we had 8 primary progressive and 16 secondaries. And if you look at it, the number of people that improved, 25% versus 6%. The number that were worse were 37 versus 62. The people that were the same were about equal. And the mean change in the EDSS favored the primary progressive. So in all our measures, it looked like the primary progressive, the group that should not respond, did the best. So it just goes to show that we don't really know as much as we think we know. And this is the graph of that. The blue is the secondary progressive, and as it goes up, that's bad. And you can see that they got a little bit worse, whereas the primaries on the red line stayed about the same. So where do we go from there? We currently have another study that's in the design phase, and we hope that it will start up in the next few months. It's going to look at relapsing remitting MS because prior to this latest data, we thought that maybe the people with relapsing disease would be more responsive to immune-directed therapy. We're shifting the EDSS down because we think we can do this much more safely now. And we think that if you're going to have an influence on the disease, that the earlier the better. We want people that have active disease, so it'll be people that have had 2 attacks in the last 12 months and with their EDSS worsening by at least half a point. Or their MRI criteria, that if your MRI looks very active, you could qualify as well. And of course, we want people that have failed more conventional therapy. The plan is to do an additional 30 patients with this new protocol to give prednisone that's a steroid when we give the GCSF. This time, instead of doing the radiation, we're going to use beam, which is a combination of these 4 chemotherapy drugs, and then transplant them, otherwise very similar to what I outlined. We will look at a 5-year endpoint for this, with the main endpoint being a worsening of the EDSS more than 1 point. We're also going to look at the MS functional composite, which is probably a better way to measure disability in MS, as well as relapses and several quality of life measures. There's still a lot of unanswered questions with transplants like this. One is, in the absence of a control group, we don't know how this compares with less aggressive and less dangerous treatments. We also don't know what protocol works best. The oncologists have argued strenuously about whether to use beam or radiation-based ablation therapy, and I think we really don't know which of these might be the better one to use. We also don't know which group of patients responds best, whether we should use it early or late, or inflammatory or non-inflammatory disease. The other thing we don't know is whether allogeneic transplants would be helpful. With the ones that we were doing, we gave, as I said, the patient's own bone marrow back. But you might question, well, maybe they would do even better if we gave them someone else's bone marrow and just totally got rid of their immune system and gave them a better immune system. As I said, the prior death rate from that would have been 30%, but there's now a new way of doing it that would pull the death rate down to 5% or so. So it may be possible to eventually give them someone else's bone marrow. For now, however, I think it's important that people should, if they're considering a treatment like this, try to do it within the confines of a research study. One of our greatest fears is that we don't want what happened with breast cancer to happen with MS. What happened with breast cancer was a protocol was developed to do bone marrow transplants. And since you can just go to your local neighborhood oncologist and get a transplant, people decided, well, why should I enroll in this study? I'll just go down the street and get one. So it actually became the most common cause for getting transplants in this country was breast cancer. And then after many years, they finally got the study finished because they're having trouble enrolling because everyone was just going down the street to get it. And it turned out that it didn't do any more benefit than just using regular standard therapy. So our hope is that we can get the answers with this in a research setting before it becomes widely disseminated. So thanks for your attention.
Questions?
The treatment to pursue the bone marrow transplant is like radiations to the brain and there's chemotherapy, or you're re-affecting only the peripheral bone marrow. In this case, what happens to the immune cells in the brain itself?
Well, I think one of the more interesting, a good study always asks, you end up with more questions than you started with. And I think that's the case with this because we think we may have benefited these patients some, but the big question is that 27% that continue to have attacks. Why? And we don't know. It could be that the disease process in that group of patients has nothing to do with the immune system and that we're just barking up the wrong tree. Or it could be that our transplant didn't completely transplant these patients so that they still have some of their original evil bone marrow around. To that end, we've looked at oligoclonal bands in the spinal fluid, and I actually have it on my laptop and have not analyzed the data yet, but it looks like if you started out with bands in your spinal fluid, after the transplant you still got them. And the data that I haven't looked at yet is we ran the spinal fluid as a batch before and after so that we can now see is it the same band that they have afterwards that they started with. And I haven't looked at it yet, but it does bring up some questions of why does it fail when it fails.
So there's no intrathecal chemotherapy or any irrigation to the brain itself?
There's no intrathecal chemo. It's in fact, in this case, it was Cytoxan, peripheral blood. The radiation was whole body radiation, so that's about 800 centigrays. So they do get some radiation to the brain, but it's probably not enough to completely kill off all the cells. That's one reason that transplanting someone else's bone marrow might have some appeal, because it's very hard to completely, absolutely kill every bone cell in your entire body. But if you give someone else's bone marrow, then the two bone marrows fight with each other. And since you've already beaten up the recipient's bone marrow with chemotherapy, usually the transplant wins out. So after several months, you can completely eliminate their original bone marrow that way.
So the one question is, what are you transplanting back? They're CD34 cells, right?
That's right.
These are stem cells. But are they pure? I mean, I know you try to T-cell deplete them with your ATG, but even if that's 95 or 97% effective, and I don't know what effectiveness that is, aren't there still some contaminants that may kind of reconstitute the abnormal immune system?
Yeah, that's right. So some of the cells that are remaining in evil players could have been left over that we didn't kill, or we could be giving them back, because even though the concentration on that column is pretty good, it's not 100%, and we are giving them some regular cells back again.
Other questions? So you explained this, but maybe just to clarify, why do you think now that because you started with a fairly sick population, some of them were much higher, much sicker, and why you think that now you've got to shift to earlier? Because it's virtually every study that's looked at this has kind of come to that conclusion.
Right. All of the developing protocols are now shifting to earlier in the disease, and the main thoughts were to avoid the arguments about whether there's a degenerative phase, because if later in the disease we shift from inflammatory disease to one where the cells are just dying in the absence of inflammation, we'll have no influence on that. So if we have any hope of influencing it, it's probably best earlier when there's a lot of inflammation going on.
That was, in the scientific session, that was a bit of a controversial point. I mean, you may have heard of this, that Any other thoughts? Yep.
Could you just tell us the difference between these three stages of MS?
Well, the relapsing remitting is the most common, and people with that have attacks, and then they may or may not recover from that attack, but they get worse through a series of attacks, and in between attacks, they're stable. Percent of those, it's about 60% if they're untreated, go on to get secondary progressive MS, and with that, in between attacks, they cease being stable and their baseline starts sliding. So it's not, they get worse, not so much because they had another attack, but just looking back, over the last 6 to 12 months, they're just not doing as well as they were before. The primary progressive MS never ever has an attack, so right from the start, their baseline is slowly sliding.
Question, yeah.
Do you see an application of this to TM patients in the acute phase that are in the inflammatory phase that are not responding, or in patients with recurrent TM?
Question is,